Hi, everyone. Thank you so much for joining us. This is Inga Hansen, editor of MedEsthetics magazine, and we're going to go ahead and get started with today's webinar. If you have any questions during the presentation, please type them into the box on the right-hand side of your screen, and we will answer them at the end of the presentation. Today, we'll be discussing the role of genetics in common skin disorders, as well as key physiological factors such as hormones and their role in skin health. Our presenter is Sahar Swidan. Dr. Swidan obtained her Doctor of Pharmacy degree from the University of Michigan before completing a 3-year research fellowship in Bio-Pharmaceutics at the University of Michigan. She is President and CEO of Pharmacy Solutions in Ann Arbor and Clinical Associate Professor of Pharmacy at the University of Michigan College of Pharmacy. Thank you so much for joining us, Dr. Swidan.
Thank you for having me, and thank you everybody for joining us today. What I hope to do is in the next half hour to 40 minutes is to kind of dive a little bit deeper into the personalized side of dermatology, as I call it. There's going to be a lot of material and some genetics and all that good stuff. So if you would like a copy or a PDF of the slides, I'm happy to send them to you. You will have my email at the end of this lecture, and I'm happy to send them to you. So, and I always tease that sometimes genetics, it's kind of like the first day of French. You know, it's all a new language to us now as we're kind of diving into personalized and precision medicine. My background, in addition to what she mentioned, is, you know, I've been faculty and teaching with the A4M for almost 20 years now. So I've always had a passion. I was in Europe for a good part of my training also. And that's really where I learned whole system physiology and logical and physiological medicine. So what we hope to do today is to kind of bring a little bit of that information and more of that side into the dermatological world too, and give you some additional tools that you can kind of use in your armamentarium, in addition, obviously, to all the tools that you have and the training that you've had and so on. So we'll just review kind of more of the common dermatological disorders. We'll review some personalized treatment options and some things to look at that are instigators sometimes, or precursors, or, you know, makes the person, you know, susceptible to some of the dermatological disorders that you see in your daily practice. And then we'll talk a little bit about, you know, methylation, COMT, hormones, inflammation, oxidative stress, and their role in dermatology and dermatological, you know, disorders that you see. So there's really, you know, many things that affect, obviously, the skin. And we always say, really, your skin is the window to your health, or the eye to your health. You know, you always can look at the person and really, if their skin is healthy, it's glowing, you know, it's not diseased, if you will, you can really see the wellness and health in people's skin. And patients that are sick with, you know, autoimmune disorders, inflammatory disorders, cancer, you know, you really can see a lot of that, honestly, in their outward appearance and their skin. So what are the big areas that can affect skin and skin health? And now everybody, obviously, you guys are bombarded on a daily basis. Everybody wants to stay as young as possible, and they want to look like they haven't aged a day when they're 80, 90, and 100 now. So staying as healthy as possible for your age and skin is very important. And I think it's very important to have wellness on the inside and outside, in addition to a lot of the aesthetics and things that you do. So the big areas we'll look at least initially, are going to be stress, you know, gut-brain chemistry and gut, inflammation, sleep, and then hormonal balance and their effect on skin disorders. We're not going to belabor this point a lot. We know cortisol affects many systems in bad ways. It decreases stress on the body, oxidative stress. We know it kind of helps to break down collagen and skin elasticity. And if they're doing cortisol steals, that causes a lot of even aldosterone mismetabolism, progesterone steal, if you will. And so even mineralocorticoid levels and hydration levels can vary. So very important for everybody to control their stress as much as possible in today's world, because it affects, obviously, every disease, and for sure dermatological time stuff. So, you know, people need to disconnect, find their happy places, I always say, and obviously de-stress, you know, mind clutter. Nobody really gets stressful sleep anymore. If you talk to a lot of the patients, you'll see that, a lot of times, because they're so stressed during the day, and we always expect patients to just kind of shut their brain at 10 p.m. and go to sleep, they really can't. And they have a lot of mind chatter, and we'll talk about some modalities to kind of help with that. So a lot of times, stress, lack of sleep, it leads to a lot of the symptoms that you'll see, such as the anxiety, the weight gain, irritability, obviously insomnia, skin drooping, skin discoloring, collagen breakdown, and so on. So it's very important to really balance, the brain chemistry, the cortisol, the HPA axis, because that also increases inflammatory stress on the body and oxidative stress on the body. Gut. I think we're so much smarter now at learning the connection of gut disorders to a lot of dermatological disorders and even brain disorders, neurodegenerative disorders. We always said happy gut, happy brain, happy gut, happy everything. But really now we have a lot more of the science that tells us, the gut and the microbiome, how important it is for every body system. I always have to bring this up, everybody's on vitamin PPIs, ITs, right? And the body needs acid to break down food, to break down nutrients, to kill bugs, to kill, invaders that invade our body. And so many patients, are started on PPIs and they're on it for years and years and years. So their gut biome is very disrupted. A lot of times they have small intestinal bowel overgrowth. They have SIBOs, they have fungal overgrowth, SIFOs. They have a lot of maldigestive issues. And a lot of times you really see it in the skin too, bacterial overgrowth and things like that. And so sometimes it can be related to acne and other inflammatory skin disorders that you do. I love Alicia Fasana's work out of Harvard. The gut is such a complex system, and we always called it the second brain. And I think now we're probably learning that it is the first brain. It really is showing us how the gut influences everything from heart health, to brain health, to skin health, to inflammation, to joints, to muscles, to everything, and Alicia Fasano has really done a lot of work for the Center of Celiac Disease. And now, our environment is so toxic, the food system is so toxic. So really the gut is getting hammered. And that's why, historically, you've never seen so many people that have food related allergies as we do now, because a lot of times with the GMOs and things like that, the food just looks foreign to the body. And that again increases inflammatory burden. It causes a lot of, the tight junctions, because it causes an immune complex. You have leaky gut syndrome, or if you want the smart term, it's permeable gut syndrome. So very important to look at everybody's gut health, no matter what specialty you are. And definitely for dermatology, we can't tell you how many times really you cure atopic dermatitis, or you cure sometimes psoriasis, or or dramatically improve, the acne and things like that by addressing diet, as I call, remove the offending agent, clean up the diet, seal the holes in the gut, if you will, use probiotics and use anti-inflammatory type, diets and or supplements if need be, such as curcumin and boswellia and so on. So the gut microbiome is a major regulator also of the gut skin axis. So we know this bacteria that prime the gut immune system. Literally 80% of the immune system lines the GI tract. So we know gut microbiome can definitely affect all systems, including the gut skin axis. And that's why we're beginning to learn now these toll-like receptors. They recognize these pathogens that are associated with these molecular patterns. And, when they see something as foreign, they attack. But sometimes, now the system is so upregulated that you keep the inflammatory cascade going until you do exactly what I just said, which is remove the offending agents in the diets, put patients on anti-inflammatory diets, seal the holes with things like bone broth, glutamine, aloe, things like that have been really good for kind of bone epithelial relining, of the gut, put them on the good bugs, probiotics, prebiotics, good food, good fiber, supplementation. And a lot of times you'll see there dramatically many systems improve, including the dermatological stuff. Now, broccoli is good for 1,000,001 things. Your mom always told you to eat your broccoli and Brussels sprouts, but it's also very good for your skin. Why? So the cruciferous vegetables, obviously the cabbages, the cauliflower, the broccoli, they are the most nutrient dense, or sulforaphane is found mostly in cruciferous vegetable. And so sulforaphane, which is the isothiocyanate, found in these cruciferous vegetables, it's been investigated in preclinical and clinical studies as a chemoprotective agent, again, ultraviolet induced skin carcinogens. So they're actually looking at this now. Obviously, eat it, it's good for you. It's kind of an inside sunscreen, if you will, but they're really looking at sulforaphane now, even topically, to see if we can inhibit this activator protein transcription factor, which is helpful in inhibiting ultraviolet induced skin disorder and carcinogen, that we see despite, the use of obviously sunscreens and things like that. So in this one, they looked at the stability of sulforaphane for topical formulation. So topically applied sulforaphane in this PEG-based formulation significantly reduced AP1 activation after UV stimulation in the skin of transgenic mouse model, indicating that this formulation retains efficacy in vivo, and they're actually looking, to do human trials on this net. But again, no surprise, these drugs, these foods such as broccoli and things, yes, they have high amounts of sulforaphane, which protects against ultraviolet rays, but also they're huge in upregulating glutathione in the body, which is really one of the most important detoxifying substances for your body. So the patients that come into your office and they go, I'm sensitive to everything, I can't take this drug or that drug or this, they have a million allergies, they can barely eat any foods and things like that. A lot of times you'll see they're very deficient in glutathione because it is the universal detoxifier, and sometimes really decreasing the toxic burden from their body can dramatically improve a lot of things and make them less susceptible to allergens or increase their tolerance to medications or other substances, because basically their system is not metabolizing it. Inflammation. I tease in medicine and I say there's one medical specialty left. It's called inflammatology, right? Because now we can link inflammation to everything, to heart disease, to cancer, to gut disorders, to neurodegenerative disorders, to hypertension, to skin disorders, to psoriasis. And I'll go through and show you the connection of immune system dysregulation to some of the common dermatological things that you see. Also, when you have a lot of inflammation, you have a lot of oxidative stress in the body. So the body generates energy, but more toxins and waste products are produced. And if the body does not have a good detoxification system, then the patients get really sick because they're so toxic. Obviously, it's a wired and tired society, as I always say. Everybody's tired and wired. Everybody's going at 1,000,000 miles. So obviously sleep is so important for so many things. And that's when we regenerate. 36% of adults see a primary care physicians because they always say, they're tired. What about hormones and sex hormones and other hormones, even such as insulin and things like that? So a lot of times, this is not obviously the webinar for hormone replacement, and because it's debated on in different scenarios, but I always look at hormones, the really cellular messengers. So as you get older, you don't need hormones, for fertility and things like that. But what you do need hormones is for memory, mobility, and function. They're literally cellular messengers, and they really enhance that. So which hormones affect skin health? Well, all of them, right? Estrogens, testosterone, the adrenal ones, DHEA and pregnenolone. Thyroid is very important. Progesterone, pregnenolone, insulin, cortisol, melatonin, growth hormone. So they're very important to optimize hormones if the patient is an appropriate candidate for them, because again, they really help the integrity of collagen. They help hydration. They help keep the skin. And a lot of times you'll see when people lose their estrogens and some of the other hormones, that really their skin sags, it loses, you know, that bright appearance, that sparkly appearance, as I call it, you know, like when women are pregnant, their skin is glowing. They lose that because hormones are raging in pregnancy. So all of the hormones and insulin even is very important for skin health. So with menopause and andropause, obviously hormone levels decrease. And, you know, we know, and also sometimes blood glucose levels start to creep up as people age. So excess blood glucose destroys collagen. Excessive free radicals obviously leads to oxidative damage. Insulin resistance, cortisol levels, you know, so in high amounts of stress, you'll see, you know, it can break down collagen because it's a catabolic process. And when people are also stressed, and as if they get older, if they have, you know, bacterial infections, fungal infections, viral infections, that decreases their immune system, which also wreaks havoc at the skin. So definitely, you know, hormones are very important for cellular messengering, but for sure, you know, in skin health. The average male and female live about a third of their life without hormones. The average onset of menopause and andropause for most people is around 50. And so you'll see there's been a lot of studies that looked at the effect of systemic estrogen on skin thickness and, you know, how they significantly improve, obviously, collagen type 2, increase collagen, skin collagen increase by 7 to 15% to a lot higher. Melatonin, you know, melatonin is making huge splashes in, I would say, the integrative, you know, functional medicine world, because we used to think of melatonin, oh, basically it was just made in the pineal gland, you know, it put you to sleep at night and that's it. Now the science with melatonin, now we know it's also made in the gut. So, and it's very neuroprotective, cytoprotective, and it's not just, you know, good to put you to sleep. So obviously, it's made for the amino acid tryptophan, so that's why everybody gets sleepy after Thanksgiving turkey dinners, because turkey is very high in tryptophan. But melatonin is involved in hair growth. It's protective against melanomas. It guards from UV radiation, appears to play a role in repairing burned and damaged skin, antioxidant effects. So they're really looking at this now, actually looking at topical melatonin to repair some skin, you know, damage, disorder, you know, protection from radical damage and things like that. So, and it's almost our internal sunscreen, really, you know, with melatonin. So very important. A lot of people suffer from sleep disorders now for a variety of reasons. But remember, you need darkness for melatonin to be produced, and it's mainly produced between 2 to 4 a.m. So very important for people not to have lights in the bedroom, their phones. Everybody sleeps with their phones now. Blue light is the worst, you know, for shutting down melatonin production. So very important to sleep in dark rooms. And then now, you know, you want good skin on the outside. Well, you have to fuel on the inside. Very important to fuel every cell in your body, including the skin, because it's cellular energy. When the cells are fueled well, you're going to fill the fuel tank much better. So how do we fill the cellular fuel tank? Of course, eating well, sleeping, hydrating, all that good stuff. D-ribose is great for cellular. It's an essential sugar to cells, and it really works with the mitochondria to fuel them. L-carnitine, CoQ10. CoQ10 is critical. It's mainly obtained from animal protein. So vegans and vegetarians are usually very deficient in L-carnitine, CoQ10, and vitamin B12. So very important to supplement those patients, but also, you know, those are levels that can be checked to make sure that the patient has adequate CoQ10 level. Also remember, many of the drugs that the patient are on decrease CoQ10 levels. such as the statins, the anti-glycemics and metformin, in addition to B vitamin deficiencies, the antihypertensive. So, 80% of our patients is on something like this. They're either on a statin or a anti-hyperglycemic or an antihypertensive. So very important to look at CoQ10 level and supplement them if they're on medications that lower it, or especially if they're vegans and vegetarians. So it is literally a third of your mitochondrial energy comes from CoQ10. Definitely you get it from fish, shellfish, meats, broccoli, spinach, and nuts. But again, it's mostly available in animal protein. So very important for CoQ10 for cellular energy. And magnesium is literally one of the major main minerals that is like the spark plugs that really kind of turns this metabolic pathway into high gear. So kind of moving on, what I'd like to do next is to move to some of those common dermatological disorders and see ways that you can integrate some of these, modalities that we talked about. And I'd like to also kind of introduce you to some of the genetics that have been identified to see if the patient is going to be more susceptible to certain dermatological disorders. So psoriasis, right? So I'm not going to bore you with all the phenomenal stuff that you already know. Obviously very chronic and common skin disorder. You see the erythema, the dry skin, the scaly patches, and so on. Definitely it's an immune mediated process, and definitely genetics have been identified to play a role in maybe increasing the propensity of a patient to develop psoriasis or not. So they have the genes, but then now we have to look at the epigenetics or the environmental exposures that's turning these genes on. So some of the triggers for patients, you hear this all day long, whether it's injury, sunburn, infections, drugs, stress, alcohol, tobacco, obesity, and so on. But, I'm going to make really or immunology for derm, simple today, because you're always going to keep hearing these toll-like receptors that basically upregulate the inflammatory cascade and increase inflammatory mediators, right? So TNF-alpha, interleukin, Th17 dysregulation. So this is what happened. These keratinocytes secrete these antimicrobial peptide. Okay, this LL37 stimulates these, excuse me, these toll-like receptors in dendritic cells, and then they migrate to lymph nodes and they basically secrete these inflammatory mediators. So you get activation of factors that drive psoriatic inflammation and these keratinocyte proliferation, and then the plaques, develop. So these are, again, they're, to some of you, they're probably going to sound like French. When I started looking into the genetics of them, right, we always have to give them these interesting names, but definitely there is a multifactorial interaction between inherited and environmental. So again, genetics and epigenetics. Genome wide association have identified more than 60 disease susceptibility region. So the big one is looking at these HLA or HLA subtype, which is basically, haplotyping. And the PSOR one is located with this histocompatibility complex that it forms. So we know definitely HLA-C expression is found significantly higher in lesional and non-lesional skin compared to control skin. So we know there is some inflammatory stuff, genetically driven, environmentally driven, to kind of cause this histocompatibility, this immune regulation, and the develop activation of this acquired immunity for that. The other thing that has been looked at is really looking at methylation status, so DNA methylation. They have really, kind of correlated now the level of methylation. And so what is methylation? So methylation basically works on the DNA histone, and basically you don't want to be undermethylated because that causes increased risk of heart disease, strokes, your inability to detoxify. And if you overmethylate patients, then you can increase the risk of all cancers. So DNA methylation is very important. So you'll see now a lot of integrative providers, they'll check a homocysteine level, which is kind of the poor man's test, if you will, of methylation status. So definitely looking at their methylation can potentially be one of the drivers for some of their, psoriasis or skin disorders. So they've looked at the DNA methylation. Now, there are some companies that do really robust methylation pathway mapping for you. So you'll know exactly where the genetic hiccup occurred in the methylation pathway. So the DNA methylation and leukocytes. Again, and this goes to the microRNA level. I'm not going to bore you with all these mnemonics, but know definitely that they've looked at this methylation epigenetics and psoriasis and its ability to upregulate, disease in those patients, looking at all these DNA histones, looking at the histone acetylase, and so on. So aberrant DNA methylation reported in various skin diseases. So that's something, it's really beginning to make more headway in your dermatological world to look at. And that would be a simple test that you can perform to look at homocysteine levels. Optimal homocysteine levels are 6 to 8. You don't want them higher than that because usually that increases the risk of cardiovascular stuff and inability to detoxify, and especially with hormones. You methylate hormones and toxins out. You don't want it much lower than 6 because, again, low methylators, they can increase the risk of diseases. So, and I know it's making like, nightmare flashbacks to you, but this is the methylation cycle that we all learned, similar to the Krebs cycle and the energy cycle. So as you see, it's very complicated. And so people can have genetic SNPs at different enzymatic pathways. That's why sometimes with certain companies, you can literally map out this whole gene SNP to see where somebody is deficient and where you might be able to intervene. So for example, if somebody has a homozygous for the gene MTHFR, 677 and 1298, and they're homozygous, giving them something like a activated B supplement. So you give them the activated B that will bypass this genetic SNP, and it'll give them like 5-methyl tetrahydrofolate, methylated B12, and then you bypass this genetic SNP, and then the rest of the wheel will go on. Sometimes you could look here, and if there's CBS upregulators, you'll see sometimes giving them some serine plus activated Bs can really help them. The other enzyme, which we will talk about in some dermatological disorders that have a genetic SNP, is the COMT. So you've heard about the COMT in relation to really neurological disorders like the COMT inhibitors, because we decrease the metabolization of norepinephrine, dopamine, and so on, so for Parkinson's and other disorders. But if people have the COMT SNP in addition to the methylation SNP, well, sometimes, like, look at your bipolar patients or highly anxious patient. A lot of times you'll see they have a double whammy with genetic, where they have a methylation SNP and a COMT SNP, in addition to some of the skin disorders that you might see. So like I said, one of the ways to bypass that genetic methylation hiccup is to give them activated B vitamins or B vitamins. So they've looked at vitamin B12, obviously, it's very important for hematological health, nervous system health, but it's also really good for the skin. So finding have implicated low or high cobalamin levels in vitiligo, atopic dermatitis in action. So again, this is something that you can measure in the office, and if it's low, supplement, because deficiency can cause hyperpigmentation, hair and nail changes, oral changes. So in vitiligo, vitamin B12 deficiency is reported. Higher homocysteine level, no surprise, because when they're low on B vitamins, the homocysteine levels tend to be up. Parenteral treatment with vitamin B12 was followed by definitive, repigmentation. Atopic dermatitis is, one of the published articles really uses vitamin B12 topically, 0.07%, if I remember the study, for the treatment of atopic dermatitis. So nitric oxide synthase inhibition leads to this decrease in pruritus and erythema and atopic dermatitis. So topical vitamin B showed significant reduction in affected areas. So again, if they're very low, supplementing them orally or even topically to the area can be very helpful for that. Too much vitamin B12 may lead to acne. Skin bacteria linked to acne release, obviously to the inflammatory molecules, and vitamin B12 changed the gene expression of skin bacteria, which led to this acne promoting. So again, sometimes you'll see patients, they're really into B12, they're taking huge doses, but remember, too much can lead to some dermatological, just like too little can lead to dermatological stuff. Also, patients with psoriasis, they have been shown to have higher serum levels of VEGF and endothelial cell stimulating, angiogenesis. So psoriatic severity is correlated with the VEGF, serum levels. So so sometimes they're using that as a marker to see the severity of those patients and see. So this is the typical stuff, obviously, that you're familiar with, the diagnosis, and in the typical treatments that's available, the topical steroids, retinoids, the methotrexates, the MABs and in UV light and so on, with the typical stuff that you have. But, hopefully this is, all the different treatments that you have. But now, hopefully, in addition to what we just discussed, you can look at their methylation status. You can look at their gut and decrease immunological stress. Put them on cleaner diets, seal the holes, put them on something to modulate the immune system once it has gone awry. One of the biggest things that's making splashes, I would say, in the immune world really is low-dose naltrexone. So you're probably going, why naltrexone? Hey, that's the drug that's used obviously for alcohol and opiate withdrawal type stuff, and it is, and it's been around for 30 years for that. But Dr. Bahari out of Harvard almost 25, 30 years ago started to look at the immune modulation and immune stimulatory effects of low dose, which is very different than high dose. So the thought with low dose is that you bind to the opioid receptor, you block it, and that increases the release of endorphins and enkephalins, which are the body's natural painkillers. But they're also, endorphin and enkephalins are very important for immune regulation and kind of modulating the immune system when it's been turned on and attacking, whether it's in skin disorders, neurodegenerative disorders, celiac disease, gut, gastroenterology, you name it. So this is kind of the history of naltrexone. And like I said, Dr. Bahari in 1985, this is what led to this. So AIDS patients had 20% normal of the normal endorphin levels. When he gave them 1% of the normal dose of naltrexone, their endorphin levels increased by 300%. So he goes, I have something here that is gonna modulates the endorphin and enkephalin system. So for pain, and then of course they looked at it for many other things, including AIDS, cachexia, AIDS stimulating the immune system, and so on. 2009, even Stanford Medical School started looking at it, and many other things with fibromyalgia. We have over 230 articles now on low dose naltrexone. Why can you almost use it for any disorder? Now it seems like it's like fish oil. You can Google any disease and use it with it, because immune dysregulation is so common with so many other syndromes now and diseases. So immune system is regulated by endorphins, and definitely we know endorphins, are the primary action in the opioid receptors. They definitely, low dose naltrexone acts as an immunomodulatory kind of help modulate all that. And so this is basically the schematic where when low dose binds to this receptor, it blocks the opioids from binding, and then the body goes, oh, I need more endorphins and enkephalins, and then the body makes it. The most important action of this is that it reduces these toll-like receptors with signaling in glial cell excitation and activation. And it modulates the TMB lymphocyte production, obviously gut and inflammation. It reduces many inflammatory cytokines in studies, IL-6, 10, 12, NF-kappa beta, and so on. And this has been shown really in a lot of different trials and diseases and what it is. And so it's a very, really nice additional tool that you can use. Now with the low dose, liver and kidney toxicity has only been reported with high dose, and low dose is 1.5 milligrams. So usually the typical way you use this, if patient is not on opioid therapy, is low dose naltrexone, 1.5 milligrams at bedtime, and then 3 milligrams at bedtime, and then 4.5 milligrams at bedtime thereafter. And that's it. You usually stop at the 4.5 milligram because after that, you would lose the low dose effect. So there has been a lot of study, 2017. So they've looked, it's a small trial, but it's definitely popping in your dermatological world, biopsy proven, Haley. One patient had 90% clearance. All 3 patients had substantial improvement in quality of life. We see it in psoriasis. You see it, naltrexone inhibits IL-6 and TNF-alpha. Definitely, they've shown this in many studies in fibromyalgia when they've measured inflammatory markers. So definitely can be, the inflammatory. It's used, LDN for breakthrough, obviously depression. Inflammatory depression. In those studies, they've used 1 milligram BID for 3 weeks. It's very effective for a lot of gut dermatological stuff. Really, a lot of colleagues are using it for a variety of things with immune modulatory effect where it's needed. 8-week study for fibromyalgia, it was shown to dramatically decrease all these inflammatory peptides, interleukins, and INF alpha, TGF beta, TNF alpha, and so on. So, and they have used it now in multiple sclerosis, in Crohn's, in fibromyalgia, in chronic pain, in Haley, in autism, in cancer. There's a lot of trials. This is the one with Haley disease with low dose naltrexone. Again, they used LDN 3 milligram nightly, and they titrated to the 4.5 milligram. Reduction in the size of lesion as well as subjective improvement of symptoms was found. So definitely it's small trials, but definitely it's gaining, more and more wide use in your space now. Vitiligo, as there's not a lot, on this, and unfortunately sometimes the treatment is limited with that, the typical stuff obviously that you're using. But again, a lot of it goes, it's autoimmune mediated destruction of melanocytes, right? So again, the HLA subtyping strikes again, these different HLA subtyping, or what we call the dreaded gene, sometimes in patients that develop these chronic inflammatory response syndrome or mast cell activation syndrome. So you'll see vitiligo, the COMT genetic SNP, has been shown also. So COMT 158 polymorphism reduced the COMT enzyme activity and leading to damage of these cells and ultimately vitiligo. How do you overcome a COMT genetic SNP? You give them glutathione, actually, surprisingly enough, and that really helps them to metabolize that and decrease that. So, possibly that might be helpful in vitiligo. Obviously, it has not been studied, but that's kind of one of the best ways that we can kind of overcome a COMT or NAC and acetylcysteine, which is the precursor for glutathione. And so that's what COMT does. Obviously, it degrades norepinephrine, dopamine, and a bunch of other monoamines. And so again, really this is kind of continuing, we are able to get, Quest and LabCorp and things like that. We're able to get the HLA subtyping on patients now and see if they have quote unquote the dreaded gene or not. This is the other HLA subtypes that have been kind of shown connection with vitiligo. Acne, again, the typical obviously diagnostic criteria that you have, but there's definitely, some genetic links. Hormonal imbalance leads to this increased sebum production. Genetics is a highly heritable trait. They've looked again at these toll-like receptors, which again are important in the recognition of P. acnes in epidermal keratinocytes. So again, we're launching an immune response towards something. So it's important to look at those. And this is obviously the typical stuff that you're familiar with. But again, gut, really anti-inflammatory diets, probiotics, low dose naltrexone for some of these inflammatory type skin disorders that we covered. And these are the typical, studies that you have in your world. This is a really nice one. It's personalized medicine prescription. We use this a lot. Azelaic acid. It's a great, obviously, it really helps, keep the skin moving, if you will. It has a DHT blockade, so if you have androgenic acne or if it's due to high DHT levels, azelaic acid is great at blocking DHT. So I love that combination. This is a compounded combination from some of your compounding pharmacy colleagues they can do for you. Niacinamide decreases sebum production. As you guys know, it has antibacterial, probably antifungal properties also in this clarifying base. This works amazingly, for acne. Acne rosacea, again, very similar. There's an inflammatory component to this. For sure, they have linked the HLA, again, toll-like receptors, where it increases the propensity of patients to develop that. So the typical stuff, obviously, you're familiar with, the, cold compresses, cold sprays, the different laser type stuff, ivermectin, obviously, oxymetazoline cream, that's, been historically used for this also. But again, I love topical, azelaic acid because it's got, the DHT blockade. You can combine it with ivermectin for the antifungal component. You can also put topical, so you can combine them all in one, the tetracycline or other things that you want. So this is, a nice gel that you could, combine together if need be with the azelaic acid. Even niacinamide may be helping and calm the skin with some aloe, and obviously ivermectin or metronidazole. So this is a common one that we do with the niacinamide and metronidazole for rosacea. Sometimes, we've some colleagues have ordered the oxymetazoline topically with ketotifen. So ketotifen is really unique. Ketotifen is a mast cell stabilizer and an antihistamine. So this is really nice for kind of mast cell stabilization, decreasing that redness, and decreasing the heat and stabilizing those mast cells, and also blocking histamine release. So this is a really nice combination where you get the vasoconstrictive action in addition to this mast cell modulatory effect in that. So those, make sure that their zinc levels are in check. Also, zinc, very important to make sure, topically, even you can add zinc topically to some of those compounds that you have. This is another different combo with azelaic acid and ketotifen. So that's a nice one. I think I'm going to hold off the dermatitis. Maybe we can do another one. I know it's 2:43, and I know you would like 10 to 15 minutes. For questions. I know this is a lot of materials, but definitely I'm happy to do another one and kind of continue this. This is my email, so I'll leave it up on the screen so you can write it. I'm happy to answer any questions, now or later. If things come up, feel free to email me and I'm happy to help in any way that I can. So with that, I think I will stop here and then I'm happy to answer any questions.
Thank you so much. This has been such a great presentation. And just a reminder, if you have questions, you can type them into the box on the right-hand side of your screen. And one question we had looking at acne, you talked about the pathogenesis. What are some of the differences when you're dealing with adult acne, people in their 30s and 40s versus when we're looking at teen acne?
Yeah. So, a lot of times I think it tends to be some of the similarities. You'll still see kind of a dysregulated gut, so gut disorders. We'll see, sometimes bacterial infections, things like that, SIBOs. But I think what we tend to see in adults would be a little bit more of the hormonal component. You'll see like in patients with polycystic ovarian syndrome, right? They tend to have high androgen load. So sometimes if they tend to be more androgenic, versus estrogenic. So sometimes we'll measure hormone levels, measure DHT levels, measure, free and total testosterone along with DHT to see if there is some things that we can manipulate there if they're present. So for example, if somebody has high testosterone, obviously in addition to the normal workup you would do for polycystic ovarian in treatments, like we may use something like saw palmetto, which blocks 5-alpha reductase and decreases the production of DHT. So sometimes that's very helpful. If they're on DHEA supplementation, and if it's too much for them, then you can switch them to something called 7-keto DHEA, which is less likely to be, and it's not metabolized, to testosterone and DHT. So we definitely look more for the hormonal component, bacterial gut kind of component, and then, topical, bacterial load and things like that, and immune dysregulation, inflammatory type stuff. Like we'll see this commonly, you'll see sometimes with Lyme disease patient, right? Their system is so inflamed, or if they have chronic inflammatory response syndrome, or, they got exposed to a toxin at work and they got really sick, and then you'll see sometimes their skin is inflamed all over. We're seeing a lot more now to like what we're calling mast cell activation syndrome, right? Those are the people you can literally draw Picassos on their skin, right? I always say that's such an easy test, dermatographia. You see it so much more now because I think more and more people are inflamed from, environmental exposures to diets, to stress, to lack of sleep. So really the mast cell system is so upregulated more in patients now.
And you had discussed that topical vitamin B12 having a lot of benefits for the skin. And we had a question asking if you can use the topical form of vitamin B for nail and toenail concerns.
Yeah, so I don't know if they like for nail and toenail concern, are they asking just for nail and toenail health? Then, of course, like biotin, I think is the one that's been most touted for that. But absolutely, all the B vitamins can really help with nail health. Like that's one thing. You can look at people's nails, and if they have those white ridges, a lot of times that can indicate zinc deficiency. So the nails can tell you a lot sometimes on the nutritional deficiencies that patients have. But absolutely, B vitamins, because they're so important for so many cellular enzymatic functions in the body. They're great for everything from hair to nails to stuff. Obviously if it's fungal like toe infections, there's definitely other topical treatments like, you can compound terbinafine topically and avoid a lot of the systemic side effects of obviously oral terbinafine with liver toxicity, drug interactions, and so on for sure.
And if you have a patient who's undergoing a cosmetic procedure, particularly like laser resurfacing, microneedle, do you have any recommendations in terms of supplementation or pre-treatment diet that can help with the healing?
Yes. So definitely, I think, anti-inflammatory diets are really good, gut, right? Because again, like if you want to optimize all the amazing stuff that you guys do, and I'm always in awe with all the aesthetic, stuff, and obviously then you got the medical dermatology, but it's so great if it can be combined with the inside, if you will, right? So absolutely, anti-inflammatory diets, I think, will make your treatments much better. People will be less inflamed and therefore won't get as inflamed as they normally would. Now, some inflammation is good, right? That's how you heal. So, you know, when you microneedle your laser, you're causing inflammation for a reason, because you want the skin to heal, obviously, and resurface and all that good stuff. So absolutely, some inflammation is needed for the regenerative process, if you will. But when they're overinflamed, they definitely, your procedures will not take as well because they're so overinflamed. So anti-inflammatory diets, probiotics, I mean, we love them. They're literally signaling molecules to the inflammatory system. They've been shown to actually even alter IgE mediated peanut allergies, so the most severe kind. So the point is they modulate the immune system. So I love probiotics. You know, everybody should be on them. You know, eat fiber, eat, you know, anti-inflammatory, and then using, you know, some topical soothing emollient type stuff post procedure to kind of, you know, keep the skin hydrated. If they have hormonal issues, you know, again, depending where you go in that, either if you're doing that or some other colleagues, optimizing hormone levels can definitely help with skin, you know, collagen production, hydration, keeping the matrix more taut, if you will. It can definitely help in your aesthetic journey also.
Terrific. And we are running out of time. So if people had any more questions, they certainly can can email Dr. Swidan at the address right here or reach out to us at MedEsthetics and we will follow up. And also wanted to let everyone know that this webinar will be posted on our website by the end of the day at medestheticsmag.com/webinar in case you want to go back and review any of the slides or share this with any of your colleagues. So we thank you all for joining us. And Dr. Swidan, we thank you so much for joining us and for this presentation.
Absolutely. Thank you for having me. It was a pleasure. Have a great day, everybody. Bye.